So I greatly apologize for the problem here, and I hope that we didn't lose too many people. Just to quickly sum up what we started saying is the webinar, we really appreciate all of our affiliates joining us today. And the webinar will run until about 3 o'clock until we go into question and answer. We have Nathaniel Counts here from MHA. We have Shel from MHA of Wisconsin and Kelly Davis. You all are pretty familiar with the before stage 4 philosophy at this point. I wanted to start right away with the Regional Policy Council and the work that they've done. The RPC hosts 4 yearly meetings, including a meeting this December entitled Deflection Before Stage 4. The Council of State Governments annual conference will be taking place at the same time, and they will also be included in our meeting, which will center around suicide prevention, behavioral health at the intersection of criminal justice and immigration, and includes a presentation on a highly successful peers respite program by our affiliate. The Council of State Government employs a Justice Center, heavily focuses on justice issues at the state level. Our work with the National Conference of State Legislatures, NCSL, really developed in Boston at our meeting this year. NCSL is really great on behavioral health issues, focusing on the entire continuum of care, prevention, identification, integration. They had Debbie on as a panelist for one of the meeting sessions. Before that, in July, our RPC meeting was held at the ALEC conference, the American Legislative Exchange Council, where their priorities really are state autonomy, budget, small budget initiatives, and private sector investment in behavioral health care in jails and prisons. And then finally, our first meeting of the year in February with the National Governors Association was comprised of a briefing by Dr. J. Michael McGinnis of the National Academy of Medicine, who provided an analysis on NAM's perspective paper series, Vital Directions in Health and Healthcare, Why Shifting from Volume to Value Benefit States. Recommendations were made to improve mental health care, increase access to quality service, integrate and expand community health. We wanted to, again, reiterate kudos for our affiliates, as you all have been the reason that the Back Home campaign is so successful. The RPC really pushes the Back Home campaign, which is designed to strengthen the connection between affiliates and their local, state, and federal policymakers. We encourage all affiliates to build relationships with their local, state, and federal elected representatives at home, meaning in their district offices, inviting them to your office, writing letters, placing calls, checking in with the elected official staff, and by doing so, the affiliates establish and strengthen relationships which complement the relationships that MHA National has here in Washington. The Back Home campaign helps policymakers become familiar with affiliates and, by extension, helps policymakers remember that MHA is the go-to network when it comes to questions and answers about behavioral health. By building that relationship, we're able to really be a part of the policymaking process. So pat on your back for that. Nathaniel will quickly go over position statements, and we will go quickly through healthcare reform and into Medicaid and CHIP.
Yeah, just really quickly, we have all these position statements that sort of, I think in a lot of ways, track Mental Health America and its affiliates through the consumer mental health movement as a whole. Taking positions along the way of issues facing people, and also looking to the future. And they're revised at least every 5 years, sometimes more often, in sequence, and they're huge sort of like reviews of the evidence for whatever the topic is, tons of citations of the literature and latest findings, and have really succinct call to actions that I think are really, we try to make it so you can kind of grab and go. And so if you're at the community level, state level, federal level, you're working at a healthcare system or an insurer, there's ways to sort of operationalize that topic within your system. And if you need additional help, never hesitate to reach out to us directly. We love talking these things through.
Thank you, Nathaniel. Please do visit our website, mentalhealthamerica.net, and visit the policy tab and go to position statements to read a little bit more, and feel free to, house these on your websites as well. We want to get the message out as much as we can to the public and to policymakers. So very briefly on health insurance, we know that coverage is really important, and that access is improved by having health insurance.
Yeah, and just a note on the importance of coverage for mental health. So actually one of the funny things is there's this big experiment called the RAND health insurance experiment, which is sort of like the biggest, natural experiment in health insurance in America. And one of the things they found is the major effect of not having insurance beyond any of the healthcare payment outcome or financial outcomes was depression. The people who didn't have insurance were just more depressed. And then relatedly, from a before stage 4 sort of perspective, if our whole goal is to get people services as soon as possible, as soon as they need them, not having coverage for mental health services incentivizes you to wait. If you start feeling, on beginning symptoms of a mental health condition and it's not covered by your insurance, you might wait until next year when you change insurance, or the year after, until it gets so bad you're willing to pay out of pocket. And we know from all the research that it's way easier to treat things earlier, and it's less of a human cost when we get things as early as possible. So we think it's really important to make sure people have consistent coverage for mental health services.
Absolutely. And just to quickly go over some of the work that all of us have done, including affiliates, we have, over the last year, had tens of meetings with House, Senate, and administration officials. We've submitted several regulatory comments on CMS, HHS, Social Security, and other agency regulations. We have written individual organization letters and coalition letters to Congress on each of the healthcare bills that came up. We had a really comprehensive letter to governors, and that started the conversations with governors and some of their affiliates and building that relationship. Of course, we have our action alerts and blog postings and our emails. So really give yourselves a pat on the back for kind of holding off healthcare repeal this year. And although the margin of votes is shrinking and getting smaller, and our victories may not be as safe and as we would like them to be, we know that affiliates and MHAs have just had a major impact. So thank you for that. I'm going to, for the sake of time, quickly give Shel the floor for Medicaid and CHIP. Shel, take your time, and we will try to get back on track in the next section.
Okay, thank you. I'm hoping people can hear me, and thanks all of you for hanging in during our earlier silent meditation period. So for this section, we want to direct you to position statements 14 and also 11. The federal government plays a significant role in mental health services, not the least of which is through the Medicaid program, which is the single largest payer of mental health services. And of course, we want to make sure that those services incorporate recovery-based principles and practices. So please review our position papers on those. So I am about advancing this, and I know it says I have control, Caren, but I don't have control. So Not yet.
You know,
the joys of our modern technology. There we go. You can just keep it in advance. It's pretty clear, I think. So
okay, we'll do that here.
Yeah. Good. So with the Senate's failure to pass health care reform legislation earlier this year, the actions moved to using administrative policy to support changes to the Medicaid program. Last week, the Center for Medicare and Medicaid Services announced some pretty significant changes in the 1115 waiver program that will both expedite waiver approvals and potentially modify the nature of the Medicaid program. So the 1115 waivers allow states to test new approaches to Medicaid that are consistent with the objectives of the program, as long as they are budget neutral for the federal government. And you can advance the slide. But part of what CMS did last week was to modify the stated objectives of the program. Formerly, the main objective was to increase and strengthen overall coverage of low-income individuals. Now the objectives focus on altering the behavior of individuals. Medicaid becomes a pathway not to coverage, but to positive outcomes, responsible decision-making, upward mobility, greater independence, and improved quality of life. Now, however worthy these goals may be, they are not, in fact, consistent with the congressional intent of the program, which is noted on this slide. It really is a program for low-income individuals, and the scuttlebutt is that court challenges are likely with regard to some of these waiver requests. So if we can advance the slide. As advocates, it's important to take advantage of the transparency requirements that are part of the 1115 waiver program, which have 30-day comment periods at both the state level before they submit their waiver request and at the federal level. So that's a time to provide input and comments on what your state may be requesting. So there's a link here to CMS and how to find out any waivers your state may be requesting. Families USA, for those of you who use that site, also have some very good resources on 1115 waivers. So next slide, I will note that a number of states are using 1115 waivers to provide enhanced behavioral health services in ways that are very consistent with MHA's core values and our position statement, such as integrated care, use of peer supports, and supported housing employment. So what I'd like to do is take a little bit to focus briefly on 3 areas of pending waivers, some of which have not been previously approved, that represent serious threats to access to health care. And I happen to be familiar with these because Wisconsin has requested all 3 of these types of waivers. So the first part I want to address is waivers to allow premiums for recipients. This has been approved in Indiana and was also allowed under a pre-ACA waiver for childless adults here in Wisconsin. And while the rationale is to enhance personal responsibility and encourage better use of services, the result in those states has been that 20 to 30% of recipients lose coverage as a result of failure to pay. And one of the issues here is that many low-income recipients don't have bank accounts or credit cards. They're unbanked, and those are ways people actually pay for premiums if, in fact, they have adequate funds to actually pay the premiums, which, of course, is an issue for some people. So the premium requirement really becomes a pathway to losing coverage. The second type of waiver request that we're seeing is for drug testing. And drug testing is framed as a way to make sure this potential barrier to employment is identified and addressed. However, the risk associated with taking a positive drug test, and finding a positive outside the protections, the confidentiality of a healthcare setting, deter people from compliance. And the burden of an extra visit to complete the test is also a barrier. Studies have found that very few people are identified through this process, and because treatment is not widely available, it is not clear how effective identification is in actually addressing the underlying issue. And then finally, perhaps the area where the most activity is occurring is around work requirements. This, of course, is seen as a way to move people off of Medicaid and reinforce personal responsibility. The fact is, however, that the vast majority of non-disabled adults on Medicaid are already working, or they are caring for a family member or in school, circumstances that often qualify people for an exemption to the work requirement. But a failure to meet the requirements can lead people to lose their coverage, and that potentially causes them to become more ill and less able to work. So it really doesn't serve the stated purposes. And of course, the idea that people will be able to leave Medicaid and get health insurance through a job makes sense only if the sort of low-paying jobs many people are able to get have insurance as a benefit. So this is a very concerning change in the direction of the program. So thank you. Okay, and we have here the states that have requested the work waivers. So I'm done, Caren.
Okay. And this is Nathaniel. One of the interesting things was some of the states that have already requested waivers sort of in line with these philosophical changes. Oklahoma got denied its waiver request. I don't know if we exactly know why, and I don't know exactly what that means, but it's just sort of an interesting beginning to this whole process.
All right, now moving forward a little bit to children. So of course, many children are covered by Medicaid. However, there are some children whose families make a little bit too much money and would qualify instead for CHIP. All states have CHIP programs. The Children's Health Insurance Program is kind of falls under our prevention and early intervention bucket because if we can get children the care that they need very early on, we know that that reduces costs in the long run and helps kids live healthier, more productive lives. Unfortunately, right now, Congress is dragging its feet on CHIP reauthorization, which expired on September 30th. The ACA repeal kind of took priority at the time. So CHIP reauthorization has only passed the House of Representatives, and it passed with some offsets that are not necessarily what we would advocate for. MHA has met with members of the House and Senate, sent letters on the importance of funding CHIP immediately, and we've done calls on social media for people to contact their legislators around this issue. We certainly need continued help from affiliates to send the message to Congress that it's not okay for them to take funding from one good health program and put that towards another. We want to have a full, range and continuum of care, and our safety net system is really important to that. And just a point on Medicaid, there is a program that is very critical, and the Early Periodic Screening, Diagnosis, and Treatment Program under Medicaid, which a lot of states have not necessarily done a great job at implementing, but one state that really has is Massachusetts, and we actually have a new affiliate joining very soon, and we look forward to working with the state of Massachusetts on CHIP and Medicaid issues.
And Medicaid covers, I think, 40% of all children in the United States. So it's actually, I think people tend to think of Medicaid and adults, but it's a major, major payer for children. And the sad thing, too, is thinking about like Massachusetts and being sort of a leader in coverage for kids. Massachusetts got sued, and that led to better implementation as part of the lawsuit. But its rate of screening for kids, which is, sort of your entry into behavioral health services, is still only around 63%. So 63% of kids get screened at their visits. It should be 100%. And of the 63% that get screened, I think the percentage who get high quality services and get towards good outcomes is, I'm sure, much smaller. So there's a lot of work to be done to get from the promise of early periodic screening, diagnosis, and treatment to practice.
Thank you, Nathaniel. Actions taken by MHA on children's issues range. We have affiliates probably in every state that we have affiliates working on children's issues, and in particular, at an RPC meeting earlier this year, the New York State affiliate presented on their Mental Health Education in Schools Act, which was signed into law this year. And this program would require all public school systems to provide mental health education as part of the curriculum. So that work is really important, and we look forward to doing more collaboration with our affiliates on this type of on early intervention and prevention of mental health. We also have our custom screening links, and at this time our Screening to Supports platform is recently launched. Our website will now provide customized information to any visitors that take a screen, and affiliates have the opportunity to provide their content in this platform for the use of the public. That's another way that we're partnering and taking action. And then finally, the Healthy Schools Campaign framework, Nathaniel can tell you a little bit more about.
So last year, the W.K. Kellogg Foundation funded Mental Health America to work with Trust for America's Health and the Healthy Schools Campaign on mental health in schools. And as part of the process, this was happening right after the Every Student Succeeds Act was passed, which was, for people who remember No Child Left Behind, the update, sort of comprehensive reform to that for elementary and secondary education. And deep within the many hundreds of pages of Every Student Succeeds Act are just countless opportunities to promote mental health in schools. The challenge is that the way Every Student Succeeds Act was drafted is it's very state-run and state-focused. There's much less of a role for the federal government and for really, honestly, national organizations in its implementation. Each state writes its own implementation plans that look, people always joke about how different Medicaid plans are, but I think these Every Student Succeeds Act plans are designed to be even more different than that. And then with even more variation down at the local level. So we teamed up with Trust for America's Health, Healthy Schools Campaign, and Alliance for Healthier Generation to put out a guide on leveraging ESSA to promote mental health at the local and state level. It's on our website, and we can disseminate it again after this. I think the size of the opportunity is really immense, though. There's written into the bill with so many requirements for community engagement at every single point. And what we've heard is schools are hungry for community engagement too. They're not well set up to figure out how to address mental health, even though they're interested, or even reach out to community stakeholders and figure out how to work with them on these issues. So the people who come prepared and knowledgeable, I think, really have a huge advantage in making positive change in their communities. We did our best to kind of do a step-by-step and explain everything, and we would love to support your efforts in making change at the local and state level as best we can.
Next, we have a couple of position statements on our website, really deal with children's issues in particular. It's actually the largest section on our website, so it would be great for you to take a look and kind of see. We have generally our recommendations are universal screenings, and this is what we kind of talk about in all of our meetings with folks. universal screenings in schools, primary care, and OBGYN for women who are pregnant for prevention. It's really important we have community outreach and education as a main call to action. We really want to continue building the bridge between schools and clinics, and this will be especially useful as we move towards value-based care. And then, of course, we want culturally and linguistically appropriate guidance for parents and their kids or their teachers, and so that they can have a shared decision-making process once maybe a diagnosis is made.
And I think a lot of these issues keep me up at night, but the issue about obstetrics and pregnancy is really just huge. There's all these great work coming out around screening for perinatal depression, anxiety, substance use, all coming out, and it's getting built in different electronic health records and accreditation for hospitals. So even though people are more and more implementing screening, there is not a clear pathway for many systems about what to do next. I mean, sometimes they can refer, but really the biggest problem is even after you screen, there's not a real strong expectation that you attain outcomes. Like if you notice that a pregnant woman is depressed, I don't think our system currently really expects that to be better by 6 months postpartum. And I think, quality measurement and building that expectation is important, but I think we need a lot of sort of systems level work in building those pathways to make that possible. And addressing that just gives families such a stronger start, and there's so much research linking, parental behavioral health in the early years to later outcomes for the children. So we're working really hard to try to set that up in a way that's practical on the ground.
And as we move on, the importance of the changes that we're making to these systems is kind of compounded by the fact that there is also barriers to access to care and treatment. So the ACA, of course, expanded coverage to an additional 20 million Americans. However, barriers remain in place for people, including cost, fail-first policies, lack of data for proper reimbursement, and workforce shortages. So we know that less than 9% of people have access to actual evidence-based care therapies for behavioral health conditions.
And one thing we work on a lot, this is sort of really, really, really challenging, and we wrote a health affairs blog post on it with Kennedy Forum, is what do you do when a service, we can't even tell if a service is covered under insurance or not because no one is providing it. So the example we go to is this one intervention called collaborative care model. There's 90 randomized control trials supporting its effectiveness for anxiety, depression, substance use, all sorts of different conditions. And we can't really tell if insurance covers it or not because basically no one provides it. And no one provides things when they're not sure if it's going to be covered because they're not sure if they're going to get paid. And so we have this sort of bizarre chicken and an egg issue that we're working on. And I think there's a lot of opportunities at the local level to support providers in offering new evidence-based services and then working with insurers to make sure that these things are really covered.
We have two really good position statements on access to medications and evidence-based care. Please take a look and just kind of digest that information for yourself. MHA in the access to medications policy statement, position statement, our policy is that decisions should be clinically based on prescribing medications based on what's best versus what is economically feasible or economically contains costs for the payer. And then on the evidence-based side, MHA is dedicated to accelerating the use of evidence-based practices. So the fact that 92% of the population does not have access to evidence-based therapies is somewhat, it shows that, things could be a lot worse. Our State of Mental Health report came out last night. I hope you guys received and were able to take a look or at least begin browsing it. And we still have a lot of work to do in the state, in especially making sure that in addition to having access, people have access to the best therapy that they can get. We pulled a couple of policy recommendations from each. These are ideas that we would love for affiliates to bring to the payers and providers that they work with in order to improve access in terms of the best prescription, edit provider training, prescription algorithms, exempting psychotropic drugs from restrictive policies such as preferred drug lists and fail first requirements. We want payers to take into account patient history and financial ability versus what the payer just wants to put on their list when it comes to a specific medication. And then on the evidence-based care side, MHA believes that there is a formula and it will take a lot of investment, but if we can create a practice learning behavioral health system, incorporate peers and people in recovery in all steps of the process, make sure that patients or people with lived experience have aids for financial literacy and are able to kind of see data and analysis that shows them what treatment they have options of getting is good for them or why it may not be the best option for them. And then we need funding for more trials and the dissemination of the data that is showing. So there is a lot of data out there showing evidence for evidence-based therapies, but we need to put it in front of the people who are paying for treatment so that they can, of course, start using them. So MHA of New Jersey did a really great study on network adequacy and kind of told us what we already kind of experienced as part of the behavioral health community, which is within a network. Many providers are not accepting new patients. Many providers are unable to be contacted because they don't have the right contact information listed. And so finding a provider within an insurance network is really a challenge and poses a barrier to care. Some of the work that affiliates and MHA has taken are letters to state directors on against step therapy and fail first policies, against formularies or preferred drug lists, which require people to take therapies that don't work. We have certainly been garnering support for 42 CFR Part 2 regulations, and this is a really good time to continue that work on this regulation because of the number of people that are affected by the opioid epidemic. So we have some kind of teeth behind that right now. And then, of course, informing policymakers and payers and providers that there are treatments that work for some people and don't work for others, so making sure that options and choices are there for people to decide from. That's a really big point of advocacy for us right now.
And a note about 42 CFR Part 2 for those who aren't, just deep in reading regulations, memorizing them. It's the regulation that implements a law back before we had really any health insurance coverage of substance use services. The federal government began providing direct coverage for the earliest services because there was just nothing in place and insurance wouldn't cover it. And so the law made it so basically people had some privacy rights when they were getting these services. And 42 CFR Part 2 implements that. That was 20 years before HIPAA was passed, which gave just sort of general privacy rights to people's health care. And the problem is when you have both in place at the same time and they're not streamlined with one another, then you have like duplication of privacy forms, which makes a nightmare for people doing electronic health records, which is already a challenge in and of itself. And you have all sorts of issues around data integration, and then people in practice get prescribed the wrong medications or medications that conflict with their other medication or their substance use, and it's a real danger and hazard to people.
Okay, so moving forward, I'm going to breeze through Parity really quickly so Kelly can come on and talk about expanding the use of peers. I know that a lot of affiliates, and really another pat on the back to all of our affiliates that have been involved in coalition work around implementation of Parity. As you all know, the MAPIA Act established Parity, and ACA really expanded it. Parity laws have been passed in Parity laws have been passed in Montana, in Tennessee, and in Texas. Work on Parity implementation continues in Connecticut, Georgia, Illinois, Minnesota, New Jersey, Ohio, and Pennsylvania. And a lot of this work is really tracked on the Parity track website. The coalition, including MHAs, has put together model legislation. There's a portal to file a complaint when someone is not sure that their insurer is providing Parity for behavioral health services. And the website's really cool in that it's just really a catch-all for all states around the country.
And you might wonder why you would want a state parity law when we have a federal parity law. And the federal parity law, while being amazing in many ways, is just so hard to enforce because it's so, like, parity in practice is such a detailed, complicated thing. And state engagement in this process is really important, both for clarity and because what's happening in your state with regards to parity might be different than other places. So it's important to have stakeholders engaged at every level in making this actually have meaning in practice.
Okay, at this time I'm going to hand it over to Kelly so she can talk about some of the work that she's done with you all. You might know her from her work with Patrick Hendry on peers, and she actually did a really good discussion on financing peers with Michael Brody on October 30th, and that webinar is housed on our website currently. Okay, I just unmuted Kelly, so hopefully she can start now. Kelly, are you there? I actually don't see her. I wonder if she had to drop off. Oh, here she is.
Hello?
All right.
Okay.
Now, there we go. Hey, Kelly, sorry about that.
No worries. There was some muting and unmuting popping up on my screen. But thank you for the introduction. And it looks like we're getting closer to the end, so I will try to be brief. So as Caren said, I work in our Peer Advocacy Supports and Services Department. And, you know, I'm sure everybody on this call is familiar with peer support. This is pulled partially from our website and our position statement. Basically, peer supporters and peer support specialists are people in recovery from mental health conditions. They use their lived experience to model recovery, but they also have knowledge of systems and many times formal skills to support others in their recovery. And there's peers all over the country in public behavioral health. And let me see, about 42 states, I believe, have state certification of peers. And the really exciting thing, if you can go to the next slide, please, is back in March, we launched the first National Advanced Peer Specialist certification out of our national office. It requires 3,000 hours experience, 40 hours of training, some letters of recommendation, state certification, or one of our required trainings, and then it's an examination. So one of the things affiliates have been involved in is working as testing sites because it's an online proctored exam. So if that's something anybody's interested in, feel free to reach out to me. But part of why we really thought it was important to create this certification is peer support is just a rapidly growing field. And in a field where there's so many areas are feeling this workforce shortage or a lack of focus on recovery, peer support is really important, and we believe at MHA in filling the gaps in the workforce, but also making services better for everybody. And one of the other reasons we created this national certification is because peer support really has expanded in the private or in the public sector, but hasn't expanded as much into the private sector. And what we found in our discussions with the folks in the private sector is that they were really interested in peer support, but they wanted to see higher standards and they wanted to see uniform standards across the country. So through our certification, we're moving people into the private sector, which then will open up more career ladders, because oftentimes peers who like the work that they're doing are forced out because there's really nowhere for them to go. And another reason they're forced out is because in many places peers are really paid really inadequately just in general, but also given the value of the work and the value of what they bring to the table. So there's also better wages in the private sector. So here are some of our policy recommendations. Just an advocacy for peers is an integral part of all services. Money from the state, from SAMHSA, academic institutions, peers at multiple levels, addressing state statutes. So in some states, peers are only allowed to perform certain jobs in certain settings, like on an ACT team or in a drop-in center, but really we believe peers have a role in all areas of healthcare. A really cool document we just put out that I can send to folks is we did a toolkit on the rationale behind peer support and the problems they address across all different settings. An increase on the whole health focus of peers to address the 24-year premature death we see among so many people with mental health conditions. And the other thing we care about too is it's not just adult peer support services, but adolescent peer support. So especially, you know, transition age youth are a really important group that often gets overlooked, and the family supports are important to complement the work of peers. And move to the next one. Okay. And then I'll just add quickly, one of the things we were able to do, and we've been doing with affiliates, are partnerships with employing peers. So we're doing the testing sites, but also with MHA NorCal and MHA Palm Beach County, we were able to partner with them and local hospital systems to employ peers, and the outcomes have just been outstanding, and they've led to, in Northern California, a doubling of the amount of peers that they initially brought in. And with HCA in Florida, a lot of interest from their other hospitals. And sorry, I kept talking, but we're moving into our civil rights portion. And And I'll just give, I'm sure everybody knows, but the story of the Bell of Hope is really important. Back in the 1950s, when we were moving or really pushing away from these large institutions where people were left to languish and there was no hope, there was a call for the shackles that were used in the hospitals across the country, and they were melted down and built into the Bell of Hope that's in MHA's national office, but is really a symbol for how, we are moving away from that awful place where we came from to have people integrated into the community. And as you can see from our position statement, the civil rights piece is not just keeping people from harm. So it's not just that seclusion and restraint is wrong. It's not just, people should make decisions over their health care, but it's also people having a right to treatment and a right to services, and not just people having a right to, therapy or medication or whatever is appropriate for them, but also the needs that everybody has. So whether it's employment, housing benefits, systems, and peer support services, they're all important in making sure people are included and integrated into society, because we know, my whole department is peers, is that people with mental health conditions deserve the same opportunities as everyone else and are, more than able to do it with the right support. And Caren, I don't know if you want to take it from here.
Yeah, thanks, Kelly. We have two pretty good position statements that can tell you a bit more on peers and civil rights and community inclusion. And just a quick refresher or kind of highlight of some of the work of affiliates. We have peer on individual rights. We have peer programs delivering care in community settings, in particular with the mass shootings that are now becoming more and more commonplace. We have point-of-sale awareness programs that help keep guns out of the hands of people who are violent, and we also help sellers realize that people with behavioral health conditions are not necessarily the threat to violence. Public education campaigns and creation of truthful media to dispel myths. Mental Health America believes that the rhetoric that's out there that's very prejudiced and bigoted against people is a violation of civil rights. And so we try to put out there the truth, including research by academia and Mental Health America data to state agencies, law enforcement, payers, policymakers, and such, so that our conversations and our dialogue is really truthful and empowering for all people. There's a great Women in Government toolkit as well, which was released in January, I believe, and we'll have a link to that you can take a look at, but it's basically being used to inform policymakers at the state level of good ways to address behavioral health issues and how to stay away from the civil rights violations that we've seen historically. I'm going to move quickly past criminal justice so that we can talk a little bit more about shifting to value-based care, and then wrap up. I would love to have any questions answered and potentially follow up maybe on some of the topics on our next webinar that we didn't able to touch on as much today.
So the shift towards value-based payment, and the basic idea is, whereas before, right, you did a healthcare service, let's say did an 8-minute medication check, and then you put that into the system and send it out, and then the Medicare or whatever pays you for those 8 minutes you just did. And so the problem there was the incentive was for you to do as many medication checks or whatever it is you do without necessarily, or it's not tied to, the outcomes that people actually had. And you see that in recovery, where basically the entire movement that animated MHA in so many ways was that people weren't getting outcomes, and people didn't even really believe that people with behavioral health conditions could have better outcomes. So this is moving the concept of recovery into not just like a belief that people could have a better outcomes, but a real expectation on the healthcare system that that's what we're all doing here. And so the basic premise of value-based payment is you measure some outcome or process that's related to value, and then pay people based on, how they perform on that measure. And so some groups have been worried about how that's going to progress, but at Mental Health America, we've been really trying to get ahead of it and making sure that the way value-based payment plays out is recovery and person-centered, and really reinforces everything we believe in. And to that end, the two things I want to touch on that are so we revised these position statements. And so a couple of the revisions we went through in the past year, I think really interestingly reflect the ways that Mental Health America is trying to lead in these healthcare reforms. And so the evidence-based healthcare position statement, and I think you see this sort of with a lot of advocacy, is the importance of disseminating and implementing evidence-based practices. But the problem we know is that implementation fails and isn't done well a pretty huge percentage of the time. And so the position statement kind of changed. So now the focus is really on measuring outcomes that people care about and doing value-based payment to reinforce practices that work. So while evidence-based, healthcare is sort of in the background of what providers are thinking about and performing, from the point of view of the individuals, it's really about getting towards the outcomes they care about. And it becomes evidence-based because the outcomes that people care about improving is the evidence that people need. And I think also we used to have one on, I think it was like living well with serious mental illness or wellness for people with serious mental illnesses, and sort of focusing on all the sort of outside of healthcare needs that were being so poorly attended to for so many years, and still are today in many ways. But this position statement focuses on a movement happening within all of healthcare to transition towards the way that healthcare can partner with community-based organizations. And there's all sorts of new models through Medicaid, Medicare, and private insurers, and even just community-led of ways that this is happening. And Mental Health America is trying to position ourselves at the forefront of the way that this plays out with respect to making sure that it helps people's mental health in every way possible, and integrating the evidence we have learned from behavioral health into the way that these partnerships occur. And so I think this is a pretty radically changed position statement, and interestingly reflects the way that Mental Health America is evolving and leading.
So with that, we're going to close, and we thank everyone for joining us today. If there are affiliates that want to highlight their specific actions and programs in our next webinar or at an RPC meeting or otherwise, we would love to have your feedback. Please let us know what you're doing back at home. We really appreciate you taking time to join us on today's call. The second part of this series where we'll go over methods and tools, how to create an action alert, who to talk to, how to share legislator information with your membership and such. That will be on December 6th at 1:30 p.m. and you'll see an announcement go out about that. It's 3:11, so I have to thank our presenters for doing their best to ensure that we didn't go too far over the call. So thank you so much, Kelly, Nathaniel, and Shel. And if you have any questions at this time, we'd be happy to take those. And with that, it looks like folks are pretty okay. I guess we answered all of your questions before you asked them.
You did unmute everybody, right, Caren?
Yeah.
I don't see anything coming in on the chat either.
All right. Well, thank you all so much for joining. If you have any questions, feel free to send a message in the chat box or shoot an email to Valerie or me. We really appreciate having your time today and look forward to working with you in the coming weeks.